A stroke can strike without warning or with symptoms. A stroke of bad luck tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Few medical emergencies strike as much fear and apprehension as a stroke. Bringing the possibility of a lifelong disability or death, the dark specter of a stroke has been a cause for concern among many. New understanding of their causes and constantly improving treatment still do not eliminate the shadow they cast. First, let's take a look at this week's Prairie Doc quiz question. Pick the best answer. A patient experiencing signs of a stroke should urgently get to the emergency room since the clot buster drug that can reverse the stroke needs to be used within how many hours of having a clot-induced stroke? 1 hour, 4.5 hours, or 7 hours? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for the show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in on that quiz question, but we answer your questions about strokes all night. Their causes, their treatments, as they're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. We love your questions. Please call in your questions. Joining us tonight is Dr. Jeff Boyle with Avera Medical Group Neurology in Sioux Falls. Welcome, Jeff. Thank you.
Thank you for having me.
So, and here it was, we had this set with Dr. Persons for like 3, 4, 5 months, and he has a death in the family, and so yesterday I called and you came in as a stand-in, but you're not just a regular stand-in guy, you're an MD, PhD, neurologist, stroke, the head of the stroke club, or whatever it is.
Yeah, stroke programs.
Yeah, so you're our man. Tell us a little bit about your training, Jeff.
I went to medical school at the University of Nebraska, and then did residency in neurology at the University of Iowa, and then did a fellowship in sleep medicine after that. At the University of Nebraska, I did my PhD, and that was 4 or 5 years in the middle of medical school, sort of in the middle between the second and third year. So you kind of take a break and then
do all this neuro research.
Yep.
And it was on neurological issues.
Yep.
On which particular topic?
Sort of really down nitty-gritty cellular science and the molecular biology of medicine and how we think, and really I think it would translate probably in the next few years, hopefully, into treatments for stroke after the stroke occurs, preventing more cell death after a stroke, and possibly in like epilepsy when people have seizures. Maybe preventing brain damage for a long seizure. I mean, there's a lot of different ways to translate medicine, from the basic science to the patient. So.
And I've heard you also did your residency with a friend of our program, Dr. Jennifer Kruger, who is a neurologist in Rapid City. So.
Yep.
I got a little information about that as we came.
It's a small world in medicine.
It is a small world, isn't it?
It's nice, yeah.
So, what do you think is the most important question about neurology that we should address today, about stroke and neurology?
Well, I mean, I think the most important thing to take away is just that getting into the hospital as fast as you can.
If a new neurologic symptom happens.
Yes, yeah.
Get into the emergency room.
Absolutely.
Now, why would that be? I mean, the time starts clicking, right? What is that story?
So, when a stroke happens, there's two kinds of stroke, and the main one, 85%, a lot of the strokes are clots, and they start somewhere, the heart or an artery, and they go down and go with the blood flow, and then they wedge in somewhere, and after they wedge in, everything beyond that clot dies, or it can die, and the sooner you get in, the less dies. So there's some research and some science that says 9 million neurons per minute. So every
are dying, are going away.
They're dying, and so every minute that you wait is more injury and more problems, and so getting in fast is really important.
Well, you know, this whole treatment of a stroke with a clot buster goes along with the treatment of an acute heart attack with a clot buster, and all that happened during my lifetime of practice. And it's been amazing when it works, but it doesn't always work. So what are the numbers? I mean, there's a percentage of people who get worse with a clot buster.
Yeah.
So it's a risk. There's a risk factor. There's a risk
and benefit.
And a benefit. And the benefits, of course, in the right case, is clearly better than the risk. So what are those numbers?
Well, the earlier on, you're better. So a person comes in 30 minutes, gets the clot buster right away, they're going to do a lot better. So the benefit is about 2.5 times in that person, that they're going to have a lot less disability. The chance of them going home versus passing away from a complication in the hospital from the stroke, or going to a nursing home
and being disabled forever.
Yeah, I mean, depending on the kind of stroke that you have, but the chances of going home are 2.5 times greater in that scenario, that you come in so early. The trouble we have with the clot buster is that there's hemorrhage. So with that clot, it sticks in that artery, and then the artery dies, right? Or the wall gets weak, and then you give the clot buster too late, 6 hours, or later. And if we do that, we don't know when the stroke started, we just give it, and you're wrong about when it started, that'll die. That artery will die, and then the blood will push on through that, and there's blood on the brain. And that's what we have to say, when we did the research, one study said 3 hours, and another study said 4.5 hours. And really, both of them were good, but the American Heart Association really centers in on that 4.5 hours, that the risk of hemorrhage or the risk of cure is about even. And so that's where we take it, is to 4.5 hours.
Right. First of all, do no harm, and there's a percentage that might bring on harm.
Yeah.
But of course, something like 20%, maybe 15%, maybe 30%, but a percentage of the strokes are due to a bleed, not a clot.
Yep, exactly.
So if you give a person a blood thinner and they're bleeding, it will triple the damage.
Oh, yeah, that's
terrible.
Terrible. So we do a CT scan almost as soon as these patients hit the
and it's a simple CT.
Yep.
So,
non-contrast.
and you can tell if they're bleeding or not by a simple CT. So let's say I'm in Alcester or I'm in D. Smet, and I go to the emergency room there, and they don't have a CT, then they will send me to a place where there's a CT. So I think one of the things that we glean from this is get thee to an emergency room that has a CAT scanner if you think it's a stroke.
Yep.
And of course the question, you see it, I saw it advertised by the National Stroke Association or some organization, Neurology Association, that said call 911 and get to the emergency room. One option is that the emergency room group will get you to the nearest CAT scan emergency room, lickety-split. But if you're the one having the symptoms, don't drive.
Right. I think that's important.
It's the same way with the chest pain. If you're having chest pain, don't get behind the wheel. Call 911 or get your spouse to get you there, or somebody to get you there as fast as possible.
Yeah, driving is a huge risk, and then not only do you have a stroke, then you have broken leg or trauma to deal with, and so then it becomes much more complicated, because if somebody has an accident, they have a broken leg, we can't give the clot buster, they'll bleed, and it's just one problem at a time, please.
Yeah. So let's talk about symptoms. And by the way, let's just say again what we just said about the value of calling 911 and or getting to the emergency room at the end of the show. Don't let me forget.
Okay.
We need to repeat that message. It's so very important. But what symptoms would we have that would lend us to think that it might be a stroke? I mean, of course, some of this is not going to be a stroke, but it could be a stroke.
Yep. Yeah, and I think that's, you got to rely on the physicians and the nurses and everybody in the emergency room to really tell that. But really, it's sudden onset, and then that's a key part of stroke. I mean, it's kind of, in some ways, it's biblical that God strikes you down, and you know, when we didn't know what a stroke was, I mean, people thought it was a lightning bolt or something that hit somebody, and they suddenly couldn't use their arm and leg, right?
And I didn't realize the etymology of the word stroke, but that's it, huh? You're
Yeah.
being stricken by something.
Now, my mentors told me that at the University of Iowa. Dr. Adams, wonderful, wonderful man. But
he may not be right.
well, I searched for it in the Bible and I really couldn't find it. But he's so convincing. I'm not giving up on that concept.
You know what? Somebody out there might know
Yeah.
that there's a line in the Bible.
If we can find that line, that would be
It'd be
really
great.
helpful.
All right.
That'd be fun.
So, all right, so go on. You went to a Catholic school, right?
I did. I went to Healing down in Sioux City, Iowa, and
Isn't that interesting? The name of the school is Healing?
Healing. It's
Oh.
Heelan.
All right.
But, you know.
Yeah, maybe not. All right, so go on.
So the acronym many people are using is BFAST. And,
Okay, BFAST.
Yep. And now I'm gonna forget what it all means.
Oh,
I never use it myself. You know, it's just it's something.
Acronym. Okay, so
But E is eyesight. Oh, I knew I'd forget this. And then F is face. A is arm. S
speech.
speech, and then T is time. And
what is B?
balance.
Balance.
Yeah,
Yes.
balance. So you kind of get the whole body there. So, you know, you can have a facial droop. You can lose your vision. Those are really common in stroke. And then an arm and a leg. And you know, if your leg is weak, obviously you're going to have balance problems. But you also can have balance problems from the balance part of the brain, which is in the back.
And that could be a clot too.
Yeah.
But there are a lot of reasons for balance that are not dangerous. I mean, not every balance problem is a dangerous thing.
Yeah.
But you don't know.
Well, the sudden onset is the key, I think.
Yeah.
You know, and some things are notably absent, right? It's not painful. Strokes are not painful. Why did God make heart attacks so painful, but not a stroke? I mean, rarely do you have a headache, right? I mean, we don't see, people don't come in and say, I have a headache, and then we say, oh, you have a stroke. I mean, it's bizarre to me that we don't feel that.
Yeah,
I wish we did.
You know, I'm a guy who likes to help people with pain, though. I'm somehow, part of me is saying, no, I'm glad that they're not having a terrible headache.
But what if they had a headache, they'd come in faster, I think.
Yeah, there it would be, and then we could do something.
And then we could do something faster. It
But
doesn't
you know,
hurt, though.
the eons of all the years of humanity, we didn't know we could use a clot buster. I mean, there.
Sure.
So there it is. We really didn't know. You're right. We didn't know. So, speech loss. Now that's another one, and I would think speech loss is probably one of the most important clues to a new stroke. Go ahead.
A large part of the brain is
His speech.
dedicated to speech, so yeah, it's important.
Very interesting comment. We can talk more about the large part of the brain and the value of speech in humanity. Speech loss or deterioration is a common result of stroke and is especially impactful when you make your living with your voice. A local radio personality visited us about his experience.
5.5 years ago in March, I couldn't talk, I couldn't walk or anything. They said I probably would die. I had never taken any medicine or anything. I woke up in the morning and I could tell my right hand. But you know, old Norwegian, I don't need to do that. Well, I should have done that, but then I had the stroke and I went to Dr. Holm, and he noticed that I had the stroke. I had a number of people would work with my hand, with my leg, and they walked me in the wheelchair. Well, then I had this brace, and then little by little by little, I just, whenever I could do, that was wonderful, you know. I used to have a cat. He slept with me and what have you. Even from the very first, when I got out of the hospital, I sat with the cat in the morning and I could talk to him. I can't figure that out, but he understood me. But then I come up with stairs and talk to my wife. She say that again, you know, but the cat, oh man, he was a dandy. Some days I'll really struggle with words, and other days, man, just wonderful. So we really walk again more, I suppose 2-3 miles a day. And so then just little by little by little, I would say thanks to Doc and Katie and the other people down at Avera McKinnon, you know, oh, they were so wonderful, but boy, I was really glad to be home.
Well, we can't thank Grant Peterson enough. You know, those of you who listen to KBRK radio in Brookings, South Dakota, probably remember Grant, Mr. Norwegian. You know, there was Norwegian jokes, you know, going all the time, and lutefisk here and lefse there, you know, and Grant always had the Norwegian story, and he was a son of Norway, you know, yes. So what a joy that he has had this wonderful recovery, and I think a lot of it is his persistence and his desire to get better, and maybe it's that darn cat. I thought that was pretty good. Comments about being able to speak to an animal but not to your wife. I mean, that's very interesting, don't you think?
Yeah. You know, we think of language as kind of a, you know, should be applied universally. So people that can't speak also can't write most of the time, and so. But I think it's, you know, when you speak to something that can't really judge you or speak back, yeah. maybe it's easier to learn and rehabilitate in that way. I'm not sure.
That's a fascinating story. Made me laugh.
Yeah, that is funny.
This is your program, and your questions are key to the direction of our discussion. Call in your questions, please, to 1-888-376-6225, or send us an email to ask@prairiedoc.org. We had one message from a gentleman who had a cerebellar stroke, presented with dizziness, and now has come out of it. Could you explain what a cerebellar stroke is? Cerebellum being the back of the brain.
Yeah. The cerebellum is if you look at the brain, or look at a picture, it's a smaller sort of mini brain at the back, and it really does seem to kind of be isolated away from the rest of the cortex. And it really does a lot of things, a lot more than I think we give it credit for. It's been taught as like a balanced part of the brain, and coordination too, you know, brushing your teeth, or, you know, putting on your glasses without, you know, poking yourself in the eye kind of thing. And but really with speech too, the intonation and the fluctuations that we have are part of that. And you know, so if you lose that, it's really devastating at first, but it's remarkable the rehabilitation you can have
from a cerebellar stroke.
Yeah,
that rehabs well, doesn't it?
It does.
Usually
it does seem to.
That I often think about the animals have a strong cerebellar part too, because they're running through the forest, they're balancing like we are as well. I mean, it's an older part of the brain, isn't it?
Yep. And we use it for different things, it seems like. fascinating.
coordinating our speech.
Mm-hmm. Yep.
You know, I hadn't thought, but as you say, there's a lot of speech in the brain, isn't there? And I mean, communication is an important part of what is human.
Mm-hmm.
A Canton man says, I had a traumatic brain injury with no bleed, but 10 days afterward, nothing on my right side functioned. I came out of those symptoms, but I've had severe headaches ever since. Does this past injury make me susceptible for dementia or future strokes? And what can I do about the headaches? That's interesting. Mm-hmm. Post-trauma, brain injury, headaches. And I have a dear friend in Rhode Island that I was sailing with a couple weeks ago, and he has had severe consequences of head trauma. So the question I would have is, what do you do from that? What do you do with the headaches? How do you help people with that, as long as there's no bleed?
Yeah, and you know, post-concussive headaches and people with traumatic brain injuries certainly struggle with, a lot of people certainly struggle with pain. I mean, it's difficult to manage. I think you got to, you know, follow with your primary care doctor. If they feel like you'd benefit, you got to see a specialist and see what we can do. You know, certainly there's a lot of medications and a lot of treatments for headaches, and you know, you just got to see us. You got to get in and get seen.
Get a check out. Oftentimes, though, those medications are a little help, but not a ton of help. You know, and of course, chronic
Depends.
pain.
Yeah.
And it depends, doesn't it? It
Yeah.
does. This is he at risk for future strokes or dementia?
Well, for strokes, not in particular. I mean, we think of the major risk factors. You know, age, it seems to be a major risk factor. Diabetes, high blood pressure, a smoking history.
Smoking, high blood pressure, diabetes, those are the big.
Yep, and
biggies.
and hyperlipidemia, cholesterol problems. Those are the ones you have to see your doctor for. Trauma in and of itself isn't really a big one. You know, we worry about dementia with repeated head injury. A solitary, you know, injury is not as worrisome. It's still something you have to kind of be mindful of, and cognitive performance. But you know, it's the boxer like Muhammad Ali who had repeated head injuries that he seemed to have more of a almost like Parkinson's, and then you know we worried about a dementia with that. So.
Yeah, dementia pugilistica.
That's correct.
Pugilistica or
Pugilistica.
Pugilistica.
Yep. Very good.
So I mean, it's a Parkinson-like thing, but one trauma is not like being a professional boxer.
Right. Right. So.
A Draper man asks, does acupuncture help bring movement back after a stroke?
I think there's a lot of interest in that, and unfortunately we don't have a lot of data. Now, when we look at treatments for stroke and rehabilitation, you want to have a patient that gets the treatment and a patient that doesn't get the treatment, and then see who does better.
Right, as if you knew they're the exact same thing, but it's really hard to get that exact same thing.
So with acupuncture, you know if you're getting poked or not. So it's hard to test that and know what, you know, who's getting better.
Yeah.
There's a big placebo effect in medicine, and so certainly if I think I'm getting poked,
maybe I'm going to get better.
maybe I'm going to get better, and I think it's going to help me. And so that's what we battle with a lot of times with these treatments, is the placebo effect is just very strong. And so I can't. I know physical therapy, occupational therapy, speech therapy, rehabilitation is the way to go after a stroke.
Okay. An 85-year-old, and I would wish that we could say acupuncture makes a difference, but I think the data is not clear. You're right, that's it.
I don't think it hurts you.
Yep.
If you think it's helping you, I'm not going to say stop it if
There you
a
go.
patient says that.
A Draper man asks, an 85-year-old woman from Redfield asks, are there any medicines to take to help prevent a stroke? Now, we can argue about lipid-lowering drugs in a person who's not had a stroke or not had a heart attack. I mean, you have to treat, to prevent a heart attack, you need to treat 875 people or something along that line before one is benefited. So the benefit is very small in a person who's not had one. If you had a stroke, if you had a heart attack, maybe a statin would be helpful. If you haven't, there's some question on it. Now, I know that a lot of people recommend hypercholesterol treatment, even in asymptomatic people.
Seems like it. Yep.
We can't go into a big argument like that right now, but
No, but I mean, you know, if you have significant risk factors, especially if you had a stroke, getting on an aspirin or blood thinner, and then addressing any cholesterol problems, controlling diabetes. I mean, those, and then stopping smoking. I mean, those are going to be how to prevent a stroke, in major ways.
So the other issue is there are some antiplatelet drugs that we can use to help prevent stroke when a person has had a TIA, right? One is aspirin. We don't really know whether the right dose is 81 milligrams or 325 or somewhere in between, do we? Or what do you routinely do?
There's a lot of information on that, and sometimes the studies don't always agree. My strategy is to avoid high-dose aspirin in patients that have stomach problems, because you can exacerbate those ulcers or gastritis and stomach upset. And so 81 milligrams in many studies seems to be adequate for a lot of folks. If you forget your medicine sometimes, a physician might say take the 325 milligrams, just to make sure if you forget, you're still protected. And then the enteric-coated, that has also been suggested as not being the best idea. So if it's an 81 milligram, I say don't use the enteric-coated, just get the baby ones you can chew up, and then you don't have to worry about it not getting absorbed, which is a big
The chewable, you can swallow and they'll get absorbed because they don't have enteric-coated.
Exactly.
The enteric-coated, and those of us who have enteric-coated aspirin at home, because it's so much cheaper than the chewable.
It might be, yeah.
If you break the enteric-coated by chewing it, then you get the drug. So I always say chew the enteric-coated or get the chewable.
Yep. That's
funny?
fine. Yeah.
And then there's others, clopidogrel, which is also called
Plavix. Yep.
That's $150 a month for 30 tablets, and the data says it's about the same as the baby aspirin. Why don't they reduce the price? It's a generic drug available.
I wish I could answer that question.
And then there's a combination of dipyridamole and aspirin, and that costs
a lot more than that.
350 or
yeah.
400. And the data says that it's about the same too.
And it's really a matter of, I think, some people it's aspirin failure. They have a stroke on aspirin, and I have to prevent their next one. And so there's genetic tests that we do for Plavix, and about 15% of people or so don't process it right in the liver and make the drug, and their blood is either too thin or not thin enough, and so we have to kind of weigh these options to see which one's the best for a person.
Okay. Well, we've got tons of questions, so we're going to just roll through.
Sounds good. Let's go.
A Sioux Falls woman has a thinning artery going into her carotid. She's wondering if there's treatment. Carotid artery disease, real quickly. What do we do?
So carotid artery disease, there's sort of 4 arteries that go into the head and through the neck. The carotids are the 2 biggest ones in the front. The atherosclerosis, or hardening of the arteries, comes along with a lot of risk factors for stroke. As hardening of the arteries occurs, that thins, it makes a really thin lumen or thin tube that goes up into there.
Right.
There's different options we can do. We can do a stent, and open it up, or you can have a surgeon kind of go in and sort of peel out that hardened artery. And so those are really good options. And if it's thin enough, then you do it. If it's not quite bad enough, we recommend not doing it.
Right. If it's 80%, you don't do it. It's got to be 90% or worse, right?
Well, if they're symptomatic, if somebody says, "Oh, I get headaches from this. I get weak sometimes on the other side."
Yeah.
Then we say, "Got to do it." Doesn't matter where, how much it is.
All right. Wow.
We need to do it.
But isn't that amazing? 90% blockage, and you got to get up to 90% usually before you fix it.
Yep.
And a lot of people will have complete blockage of one of them and no symptoms.
Yep.
Why is that?
That is a really interesting question. So some people make collaterals. So this is the bypass that the brain makes.
Yeah.
Right?
Our body does collaterals.
It does collaterals. And so if you have a blockage here, you can have an artery that's coming through sort of the deep skin, come in through the head and feed the brain through the scalp, essentially, and through the skull. You can have arteries that come up from the other side and spread across.
Over to that. It's an amazing thing.
If it's a slow process, then you have time to grow those connections. But if it's a clot, it won't. You can't do that.
Can't do it.
It's not fast enough.
All right. Time is certainly of the essence when dealing with a stroke. Telemedicine can help our smaller rural healthcare facilities access the expertise needed to address a stroke quickly.
There's a great need for help in making the early, acute, vital treatment decisions for people who are suffering stroke right when it occurs and they show up to an ER. It requires expertise, and what we found is that if you apply that expertise, we're more often able to treat patients, we are more accurate with the diagnosis, and we're seeing better outcomes. So how do you spread the expertise around in order to get patients who show up at any hospital, and we're in a rural part of the country, and we're just not going to have that neurological expertise available. So there's nothing really fancy about it. It's just getting your expertise out to the patient where, a stroke doctor like myself can do my own exam, take my own history, and get a good understanding of whether or not I'm making the right treatment decisions for patients. We started work with Aberdeen with a pilot to see how it would work, and now we're creating kind of a stroke system of care that is with Aberdeen, South Dakota, St. Luke's Hospital as the hub of that stroke system of care. So each of these smaller hospitals might be able to offer some aspect of stroke care, but not all aspects. And so we do what we can at those sites by bringing the expertise into the site. And when it's appropriate for patients to stay close to home, then they can. And but if they need a higher level of care, we're helping with those transitions. This treatment decision, this early treatment decision, is the whole reason that telemedicine for stroke has just grown like wildfire, because you need that decision to be made in a timely fashion, and we're talking minutes. So there are two forms of treatment available for stroke when it's occurring that I call rescue treatment, to try to reverse the stroke before the damage is permanent. So the first one is a clot dissolving treatment called tissue plasminogen activator, or TPA for short. It's just a drug given in an IV. So and the sooner you give it, the more effective it is. We have, from the time the symptoms start to the time that we can no longer give them medication, is 4.5 hours. So, and the earlier in that time window that you arrive to the hospital and get the treatment started, the more effective it is. So literally, every 15 minutes is a 5% reduction in mortality from stroke if that treatment is given just 15 minutes earlier. So very important to get in and get treated quickly, make the right treatment decision, get the exam done, that sort of thing. The second level of treatment, if the stroke is caused by a blood clot in a larger blood vessel, that drug might not be enough to completely dissolve the clot. It might help, but it might not be enough. In some cases, we have to move patients from that rural site where we don't have this second tool to a larger city hospital where they can do what we call mechanical thrombectomy. And that's where we go up with a catheter through the blood vessel system all the way up to where the clot is, and remove the clot mechanically, either with something called a stentriver, where a stent is opened up and clasps down over the clot and you pull the whole thing out, or with a device that acts with a suction-like mechanism in order to pull the clot out. Either are very effective. 20 to 30% are going to be hemorrhagic strokes, where there can be bleeding into the brain from a breakage of a blood vessel. Easily determined, though. A CAT scan will show an area of bleeding very clearly. On the other hand, when it's the other kind of stroke, when the damage isn't permanent yet, you aren't going to see a change on CAT scan. You might see a normal CAT scan. So we do that CAT scan, and if there is no blood seen on the CAT scan, then we're able to deliver treatments that we are talking about.
Well, it was great to have Sandra talk about the value of telemedicine. I can't tell you how many times I've called down to Sioux Falls on an emergent situation. Help me, should I use this thrombolytic? We have more questions and we're going to dive right in. Thank you for this, but we want to kind of move on.
Yep.
As a woman from North Sioux City asks, I'm 88 years old, living alone. If I thought I was having a stroke, should I take an aspirin right away?
Generally, we advise against that. Get to the emergency room, and if you have a CT scan that shows an ischemic stroke or suggests an ischemic stroke, we'll give aspirin in the emergency room.
Yeah, so it could be a bleed, and it would make things worse.
Yep.
A Sioux Falls woman says, I'm taking Eliquis and wondering if there would be a generic version of this drug.
Eventually there will be, but that's a relatively new drug, and
It's expensive as hell.
it's pretty expensive. And
There's an alternative that works, and it's pretty darn cheap.
yeah, so warfarin is a medication that is cheaper. It's been around a long time. We know a lot about warfarin. We're very experienced with it, and it's an alternative to think about.
My personal bias is that it's the first choice, and particularly because you can tell if a person's actually taking it. And if you look at whether people take their medicine or not, the truth is that 40% or more don't take their medicine just right. And so I think because of that reasoning alone, even though the data says that that's basically the same as Eliquis, the results, the only difference is so tiny, but they advertise the tiny difference.
Yep.
There's about the same. Warfarin is an option. Talk to your doctor about it. One viewer asks, if a stroke comes from plaque on the brainstem, what is the prognosis for recovery, and is there any preventative methods?
So again, aspirin. For any artery disease, we really recommend aspirin over the other medications, the anticoagulants. And the prognosis really depends a lot on where the stroke occurred, and then there's age is a factor, and just rehabilitation and how good the rehabilitation is.
I think if you look at the most important thing, though, for all ages, lifestyle changes are very important. You can summarize it on a regular basis. Get a 20, 30 minutes of a walk every day. Eat less, whether you lose weight or not, and balanced diet. And the third thing is to be connected. Talk to people. The most important puzzle that you can do to prevent dementia is a conversation.
Seems like it, yep.
That spiritual connectedness is important. I'm talking to
It
a
is.
Catholic kid, of course, and so you must be particularly connected spiritually.
I think it's important. And sleep is really important too. I think.
Sleep is.
Yeah,
What
good
about sleep
sleep.
apnea as a cause for atherosclerosis?
It's related, but I think the data really has to bear out in studies. I really think that people sleep better, the heart works less hard, the brain gets more oxygen if they're treated. So.
Dr. Boyle is also a sleep specialist, and we're inviting him to join us on our sleep show coming up in April. So we'll see how we can coordinate that. A woman from Clear Lake asks, what is a spinal stroke, and can someone recover from this if their hands and feet are not working properly? What is a spinal stroke, Jeff?
So just like the brain can have
Loss of blood flow.
Loss of blood flow and the cells die, the spinal cord can as well. It's very rare. There's a lot of arteries that go into the spinal cord. So usually these follow either a problem in the aorta, that the aorta had an aneurysm, and then the spine can lose its blood flow, and then it's rehabilitation and recovery.
So there's not much more than that, not a lot of medicine.
Well, aspirin, if you think it was in part due to some, atherosclerotic disease or something else, but yeah, not a lot else.
In 2001, a Mount Vernon woman went on warfarin. Does warfarin affect her risk of stroke or heart attack?
On warfarin? Yeah, so it'll reduces
the risk.
Yeah.
I think so too.
If, you have to have some reason to be on it. Atrial fibrillation is the common cause that people are on it for stroke. Certainly if it's for another blood clot, it might not matter as much. If it's a blood clot in the leg, that generally doesn't go to the brain. So.
Right. I know that in the nursing home, so this is elderly that are very debilitated as a rule, not always, 80% of them will die eventually from a clot of some kind. Clot to the brain, clot to the heart, clot to a leg, clot to a kidney, a clot. And so, although I don't start warfarin on elderly people, but if there's a reason, I'll start warfarin. If there's an indication, and I do it because there's, people acquire clotting disorders as they get older. A viewer from Sioux Falls says her mother died of an aneurysm in the circle of Willis. Is there a hereditary basis for a brain problem? Okay, let's talk aneurysm, and let's talk Bruce Willis, the circle of Willis.
Yeah, so aneurysms are outpouchings of the artery. So the inside of the artery, there's an inner wall and an outer wall, and the inner wall sort of busts out or protrudes from the outer wall, and that aneurysm wall is weak. It's like a balloon that's filled up too high, or that it doesn't have any support, and so it can rupture. And we hope to find those before they rupture, because there's things you can do about it before that happens. There is a genetic basis for aneurysms, and so you should certainly talk to your regular physician about it. If you have a family history, especially multiple aneurysms in the family, it might lead to a consultation with a vascular neurologist or another vascular person.
But you can fix those if you can discover them.
Yes.
You put little tufts up there with
Little wires that coil up and sort
little
of
coils.
Yes, they seal it up.
A woman from Jefferson says, my husband had a stroke in 1995 and several smaller ones since. However, within the last 2 months, his right arm on the stroke side is swelling. There's also some swelling in the right leg as well. There's no redness, but it's painful. Is this normal even in all this time?
I think we oftentimes see people after a stroke, and they have swollen arms because they don't move and pump that blood and pump that fluid out of that arm. The other thing that happens is, we talked about it earlier, the clots that can form in the blood is, it stays there and it clots, and then that's more of a medical emergency to get that limb looked at. So she should probably
get in.
Get in, yeah.
Get that guy in.
Yep.
A White Lake woman asks, my grandmother and mother both died from a stroke. Is this hereditary?
Well, there are hereditary factors, certainly in vascular disease. I think diabetes seems to kind of run in families, and so we have to pay attention to these sorts of things. There are hereditary problems with arteries as well. They are generally picked up with a specialist. So, if it's a strong family history and there's no risk factors otherwise for strokes, and people are having strokes, then it might be worthwhile seeing a specialist to make sure there's nothing else going on.
Talk to your doctor about maybe an aspirin a day as a preventative, although we're not saying aspirin for 40-year-old people anymore just to prevent vascular disease. And the other is the idea of getting that walk in every day. That's a huge thing. Hot Springs woman asked, is there a relation between small vein disease and stroke? Veins. Arteries, stroke is in arteries, right?
Yeah, yep. So
a lot of people have vein disease.
Yeah, we see a lot of that. I can't say that I know of an association.
No. Sioux Falls man says, my wife was in the hospital and they took her off of high blood pressure medicines, and she had a brain bleed 3 days later and passed away. Can being off high blood pressure medicines cause a brain bleed? She took TIAs, something like this, for blood clots, and high blood pressure meds took her off of them, and she had a brain bleed and died. Wondering if there correlates.
Well, after an ischemic stroke, like I mentioned, that artery wall is weak, and so it's a balance. In the hospital, you want the brain to get the blood flow somewhere, and so sometimes, like we said, it goes around the clot, and so we generally take people off of blood pressure medicines during the first few days of a stroke to try and save the brain,
get the blood flow through it
and around it, and get the brain saved, and then. But the artery wall is weak, and so that's why we worry about that clot buster. If that artery ruptures, then it's tough.
Yeah, I think it's one of those deals. Your doctor did the exact right thing, and the bad result happened. Whether it was just an extension of the stroke, and no matter what you did, it was going to happen.
Yeah, and this is a delicate balance. Too high, too low, and you should do the best you can.
Wow. A Brookings woman says, I understand that a TIA is a mild stroke, but can you explain the difference between a stroke, TIA?
Sure. A stroke generally leads to permanent neurologic damage. So this is, in the books, in the textbooks, it says greater than 48 hours. So TIAs, generally the clot goes up, it sticks, and it's generally gone in a few minutes. The symptoms last about 25 to 45 minutes, and then we do an MRI or something, and there's no evidence of damage.
Right, so it's a temporary stroke that your body healed, but it's a clue. Get on in, let's get some studies, make sure there isn't a big stroke coming. It's a warning.
Yep.
Red flag.
May happen again. Yep.
I was in the hospital. A Sioux Falls woman said I had an inherited tremor that affects my voice. I was in the hospital. They said I had heart problems, heart failure, 2 blood pressure medicines for blood pressure. It seems like after I take blood pressure meds that I get really shaky, and if I eat, the tremor gets worse. Take propranolol for tremor. I'm wondering if I had a stroke or a heart attack. If I could have a stroke or a heart attack, and can you help? I think it's very important to get that blood pressure controlled, but not too controlled.
Sure.
And the majority of elderly people, they can pass out from blood pressure medicine. That's happening a lot more than we realize. So you don't want to be lightheaded taking blood pressure medicine periodically when you stand up. Now, I said that, and it's an important message. But what would you say to her question?
Well, a tremor comes along with a lot of different things. Sometimes
10 seconds.
it's caffeine, or there's a lot of reasons, but I think keeping on the propranolol is a good thing for now.
Stay on that propranolol. And now for the winner of tonight's Prairie Doc quiz question. Pick the best answer. A patient experiencing signs of a stroke should urgently get to the emergency room since the clot-busting drug needs to be used within how many hours? 1 hour, 4.5, 7, and the answer is 4.5. Yeah. But it's 3 hours, really. Make it sooner than 3 hours, please. Earlier, better. 9 million BET cells
9 million neurons every minute.
It was Jan Roberts in Sioux Falls who answered the question correctly. Thank you, Jan, for participating, and a book will be in the mail to you soon. We'll be right back after this.
Welcome to your Prairie Doc Library at www.prairiedoc.org. Wherever you live or travel, you and your family can enjoy free and easy access 24 hours a day. Search for a specific topic. Browse through the television shows, radio programs, and blog page. You, your family, and friends around the world can learn from physicians and other health professionals answering questions on a variety of medical topics. Visit your Prairie Doc Library today at www.prairiedoc.org.
My mother was nearly 90 years old when I noticed a change in her speech during our daily phone calls. When we got her to the hospital, the X-ray or CAT scan study of her brain implied a blood clot had formed within one of the brain arteries during the night. She was having a stroke of bad luck. They say most elderly people eventually die of a blood clot, either to the brain, the heart, the kidneys, the legs, or somewhere. This happens because as we age, we develop an overclotting disorder, or our blood vessels close off due to scarring. By definition, a stroke is a vascular problem caused when the blood flow to a part of the brain is blocked. In 80% of cases, it's a blood clot that originates within the brain arteries, or starts either in a carotid artery or a chamber within the heart and is carried by blood flow to the brain. If started within 3 hours of the event, clot busters can reverse much of the brain injury from this kind of stroke. However, in 20% of the cases, brain tissue destruction is due to bleeding, making clot busters not helpful and even harmful. Recently, the World Health Organization stated that 3/4 of all vascular problems are connected to poor lifestyle choices, such as physical inactivity, use of tobacco, and unhealthy dietary habit. The closest we get to a fountain of youth comes from living a healthy lifestyle, and aside from controlling high blood pressure, usually not from medicines. There are no shortcuts, and cholesterol meds are only minimally helpful. In recent years, we've learned how blood clots and strokes can result from two medical conditions that require special treatment. An irregular heart rhythm condition called atrial fibrillation or fibrillation may result in blood clots forming within the heart, bringing a higher risk for stroke. Atrial fib requires long-term anticoagulation by warfarin or a similar drug. The second condition is moderate to severe sleep apnea, which often causes both atrial fib and an increased risk for clotting. Sleep apnea requires nightly use of a continuous positive airway pressure or CPAP mask and machine. Many people struggle using CPAP, but unfortunately no good alternative exists. Generally, throat surgery or jaw thrust devices don't effectively treat moderate to severe sleep apnea. Although wearing CPAP can pose a challenge, people with sleep apnea should endeavor to make that mask device work. Understanding these issues just might prevent a stroke of bad luck. Well, a big thank you to our guest, Dr. Jeff Boyle, for volunteering on this cold January night to come to our studio in Yeager Hall on the campus of South Dakota State University. Jeff's insight into strokes and their causes and treatments was extremely important and pertinent. There were many great questions we were not able to get to during our broadcast time. We will continue to answer those questions on our Facebook page right after this program. So go to Facebook, Prairie Doc, and we'll be there shortly answering the rest of the questions. The flu is here. The highest rate of hospitalization was among adults aged 65 and older, followed by children aged 0 to 4. So then adults aged 50 to 64. It's still a good idea to get your flu shot if you haven't yet. Remember, it not only helps protect you, but those family and friends around you, particularly those disabled, the elderly, the young. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
It is a wide open evening. Ask your questions about podiatry, vascular disease, cancer, accidents, sleep apnea, stroke, heart attack. Ask anything about common maladies. Next time, On Call with the Prairie Doc.
On Call with the Prairie Doc is very important to a lot of people in this area and in this region because it communicates a lot of very valuable information on healthcare, medical issues, answers specific questions. This project takes dollars. We have people in studios and we have people that have to be paid and we have to do production costs, even though Dr. Holm's time, our time, the guest time is all donated. We have a great foundation called the Healing Words Foundation that oversees this whole operation and is responsible for some of the fundraising to promote these programs. So the website is prairiedoc.org, O-R-G, prairiedoc.org. Go there, donate if you're so inclined, and we thank you very much.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota,
and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
American Academy of Family Physicians Foundation and the South Dakota Academy of Family Physicians,
Avera Heart Hospital,
Dakota Allergy and Asthma,
CoBank,
Fishback Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
Black Hills Medical Society,
Aberdeen District Medical Society,
3rd District Medical Society,
7th District Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Aberdeen Asthma and Allergy,
and Swiftel Communications.